Hi guys. So today we are going to get into this article here, which is up to date, as close as you're going to get for up to date, on the differences between dissociative identity disorder and plurality. And they are going to explain in an audio recording. I don't own rights to this audio recording. It is used for educational purposes only to explain the difference between DID and plurality. Now, another thing is I'm not going to play the whole audio because it's 17 minutes long. So you're welcome to go onto this page and listen to the whole thing. It's really good. So another thing we're going to get into is some Bethany Brand and NAMI. Okay. I support those that have dissociative identity disorder that have been diagnosed with severe amnesia and deal with disabling issues because of that amnesia. If you don't have that, I ask that you please leave my page. I will not be offended. I am not here to collect followers. I do this because I want somebody that has what I have to make their process a little quicker. I am part of the studies of DID that are used to help others that suffer from this disorder. And keep in mind, I am not a psychologist or therapist, so I don't have to agree with everything. And that is a choice of my own. I try to keep things organized and up to date as much as humanly possible. It is difficult to educate on this type of DID, okay? And it's basically, it's not even about for my safety, it is for your safety as well. If you do not have diagnosed DID with severe amnesia and very bad traumatic past, I ask that you please do not engage on my page. You know, it's not going to do you any good. I also want to point out that there are different dissociative disorders, and will I touch basis on those a little bit, like BPD and things like that? A little. I talk about the differences between OSDD and DID in one of my educational videos. But again, I basically focus on what I've learned and read, because that is what helped the healing process to get where I'm at. I'm in the third stage of healing this disorder after 30 years of therapy and different therapists and assessments and psychological inpatient stays, things like that. So the thing is, I don't have plurality. Does plurality have some symptoms that are similar to DID? Yeah, some, and I don't disagree with that. But again, I just don't want to talk about that on my page because that's not what I'm learning. If you're educating on plurality on your page, cool, but do not use my content to compare. It's not the same. It's the same with if somebody is in a wheelchair or they have POTS or something like that. I'm not going to talk about that on my channel, so I respect your channel to stay on your lane and I'll stay in mine. So I guess let's get into this. I liked the audio in this because it was very helpful and very useful, and these guys are going to explain that. This is a doctor talking about the differences between DID and plurality, and I found it very educational. There are a lot of things with DID that plurality does not come with. One is the intensity of pain, somatic symptoms, reconstructive surgeries, self-harm, abusive behavior as far as like drugs, alcohol, things like that. There are a lot of different things that have to be worked through. Could there be similarities? Possibly, but I will not get involved in that. And if that is something you find offensive or you think may be of concern, then you're welcome to leave. Therapists and psychologists talk about this stuff. They have to be mutual on all things because they could lose their job. I don't have to. This is my page, and this is what I suffer with, and this is what I want to talk about.
Well, let's dive into treating DID. Treatment for dissociative identity disorder usually involves therapy to help the different identities integrate into one cohesive sense of self. Although medications such as mood stabilizers, antipsychotics, or antidepressants can help alleviate symptoms like depression or anxiety, there is no significant evidence to support only using medication to treat DID. We also avoid using benzodiazepines with DID, as in addition to the usual concerns with benzos such as addiction, falls, and car accidents, they may contribute to comorbid mood instability, which is common in these patients along the lines of borderline personality problems.
The usual therapy for DID involves the therapist getting to know the different personalities, often called alters, learning about the history that preceded their arrival, and working to resolve past traumas so that the alters can integrate into one dominant personality. This is difficult work, and the research into the specific techniques is not generally sophisticated enough to give us clear estimates of effective size for various approaches in teens and young adults. Whether cognitive, behavioral, psychodynamic, or otherwise, research surrounding effective treatments for DID has, however, uncovered more insight into the condition. Some patients are seen as naturally hypnotic, or hypnosis may be helpful for them. They can use hypnosis to access separate alters and to work on the problems that each alter is experiencing.
Now, I want to talk about this a little bit. I have never had hypnosis. I find it invading because it's not something that I feel comfortable with. I prefer EMDR. It seems to be a more easier hypnotic approach. It gives you an ability to calm and to focus on your trauma more easily while you're awake. So
There's also a technique called eye movement desensitization and reprocessing, EMDR, which has been shown to help reduce symptoms, especially those related to mood. Any treatment for DID requires a process of finding what works best for each person.
We want to ensure our patients with DID are safe from problems that might crop up due to their symptoms. These might include not taking necessary medication because the current persona is not aware of them or not reliable. They might also be more naive or vulnerable to mistreatment, place themselves in unsafe situations, or engage in risky behaviors. Patients with DID do better with a solid support system. Our hope is to engage other people as much as possible while respecting the patient's privacy. This is often challenging with family members, teachers, and caregivers who may have very mixed or negative feelings about DID. Ideally, there are people who know what's going on and understand how stress can trigger shifts between different identities. For some patients, such as young adults living alone, community health workers might check in regularly and provide that extra layer of support and safety. So, as I was saying earlier, I've certainly seen a few of these cases, but when you talk about 1 to 1.5%, and the idea that if we pay more attention, maybe we'll see more, I wonder, am I missing some? Do you wonder that too? Yeah.
It's not on your radar.
Yeah. Because this topic came up in the context of plural identity, it makes me think more about dissociative identity disorder and paying more attention to that in my differential.
So the thing also I want to bring up is that people with DID, they are most of the percent, not all, are very secluded, very quiet. They don't want to be noticed. For me, even most of the people, as Christine Cortez had stated, most people with CPTSD and extreme trauma are very well educated. They are more prone to listen. They are more prone to emergency situations. In fact, I am, as of October 2nd, taking I think it's called a defibrillator class to learn how to use it to save somebody's life. I have taken parental classes, read like Kathy Glass foster care books, Casey Watson foster care books. I've taken parental classes. I wanted to teach myself to be the opposite of what my abusers had done to me, to raise my children with love and care. So
These days, when we talk about DID, we need to address the emerging phenomenon of plural identity. Plural identity is not recognized in the DSM-5, but is gaining popularity on social media. A TikTok community known as A System has 1.1 million followers as of 2021, with 910 million views on the hashtag DID. In plural identity or multiplicity, the alters refer to themselves as headmates or system mates. They are co-conscious of each other and generally remember the events that occur during the day. This is different from DID.
did you hear that? This is different than DID. Now, they're not saying that they're invalidating the A system. They're just stating it is different. And that is why I'm trying to get through to people what I have, and those that have what I have. We don't have a problem with you being different. What we have a problem is, our problem is you taking our content and misrepresenting what it is for. And that is to educate on what we have and what we deal with on a day-to-day basis, which is different than those that have plurality.
The memory gaps are present. Individuals who identify as plurals claim that they can consciously switch between headmates, where in DID, switching occurs in response to a traumatic event or stressor.
So if you notice, she just explained that our switching occurs when we are stressed, panicked. It's painful. It's as again I had stated in multiple different videos, switching for me personally, which may be different for you, is a feeling like but that feeling before you're going to throw up. There's a hot rush, there's this panic, a headache, and my head's pounding, and my eyes sometimes will dilate, I will shake, there's shifting of my eyes, and sometimes somatic symptoms will occur in my body where the trauma had taken place. It will feel like that trauma is happening again. And that is the difference. I'm not going to give myself different names because I feel like it. I'm not going to change clothes because I feel like it. My alternative states of my mind are a protective coping mechanism in my brain. When scans were done and there was a head cap put on me, my brain would shut down in one place and light up in another, showing a shift in alternative state of the mind. Moods will change, facial expression can change, body imagery, vision, even my blood work has changed. I've had it where switches can take place and my white blood cell will be different. My blood pressure will change. My body temperature will change. So I hope that gives you a little idea on what they're talking about here.
This allows people who identify as plurals to function in day-to-day life, work, and relationships, since there is less strongly partitioned memory.
This emergence of plural identity on social media platforms is driving a growing interest in the phenomenon. Some related research exists, particularly studies on what's called internal family systems therapy, IFST.
So what they are talking about there is, Colin Ross calls it the parental role. I've had other people that suffer from DID, like Shirley Davis, who also educates on DID and holds a bachelor's degree in psychology and is working towards her master's. I don't know if she's got it yet or not. However, we both agree that parenting your alternative, smaller aged regressed states of your mind is best if you can get to know them once that amnesiac barrier has been lifted, connecting basically the age regressed state with the host. So once that is accomplished, there can be work that is done. And the idea is to learn how to parent yourself. I had to read books on parenting. I read a lot of them because I wanted to know how to take care of not only my children, but myself. So.
The IFST model proposes that individuals, all of us, possess different internal parts or personalities. And we talk about this in everyday life. There's a part of me that's upset. There's a part of me that's also pretty happy about this. You know what I mean? So it could be like two different people the way IFST talks about it. The idea is that sometimes these parts are in conflict and need to be identified and help resolve their conflicts. So we can use this metaphor in everyday practice, right? Some of you is afraid of leaving for college, another part of it really needs to get away from home and be independent. IFSP elaborates on this kind of thinking in a manner that conceptualizes all of us as living with an entire community or tribe of fully developed internal personas, and the research on identifying and resolving conflicts between them is actually pretty impressive, metaphor or not. These ideas make the concept of plural identity sound quite typical or even normal, despite the air of exceptionality that proponents from the plural identity community online will often exude. In any case, plural identity to these people is not a problem but a way of being. And while families may be confused by the idea, the patients who are coming not for plural identity, but perhaps for other difficulties, such as depression, typically just want to feel understood.
What is the difference in functional impact between DID and plural identity?
That's a great question. So, the whole point of DID is that it may cause impaired function. That's the same for most DSM diagnoses.
So he's impaired function. So when I was assessed, I had a lot of things that were impaired. My math level and spelling level was low, especially my math. My math is at like second grade. But then when tested for my survival skills were at, I do believe it was 138.9. Because of my will to live, I learned how to survive off things that normal people wouldn't. An example would be like when Sister Mary used to lock me up in a particular room. She'd let me out once, twice a day to go for a walk. I was meant to be water and food deprived, and she thought she was going to get away with that. What she didn't know is that my mind was 3 steps ahead of her. When I walked in the grass, I had my socks on under my dress. And when you walk in the morning, there's dew on the grass. So I walked that ditch, walked it over and over, soaked my shoes and socks. She didn't know why, but I did. And when she put me back in my room, locked the door, I waited for her little clunky feet to walk down the hallway, and I slipped my socks off quickly, wrung the socks into my mouth for water. So I had water. And there would be times where she wasn't completely watching me. So food-wise, I'd grab purple clovers, white clovers. They had raised garden beds. I'd sneak in stuff here and there. I even reduced myself to eating grass because I wanted something in my stomach, because I knew I had to. These are things that people that don't have trauma don't understand and don't talk about. So
you have symptoms, but they're not causing any impact on function, we don't really call it a disorder. But with DID, with treatment, we want to foster consciousness among alters, facilitate integration into a unified whole. But individuals with plural identity perceive their alters as intrinsic to their being. They don't want to integrate them together. They get along pretty happily. They just might have depression, something like that they want to be treated. And so
what he's talking about here is that, people they get upset with me because I choose integration. Why do I choose integration? Why don't I want to be plural, okay, or have different alters and multiplicity? Because the alternative states that I have amnesia, I have body pain, I have flashbacks in the middle of the night, I have night terrors, and I don't want that anymore. They are causing issues in my life. Unlike plurality, where all of them work together, mine have conflict. They have problems with identifying the year, family members, things like that. So I prefer to, some people call it integration, some people call it fusion, where my alternative states are learning to cope, and then eventually they fuse in with me, and I get to view. So maybe you want to understand that. So what happens is with integration for me is, after processing over and over, let's start with an alter. An alter will talk about the trauma that I have no awareness of over and over and over till they learn to cope with it. And then my therapist will work with them to understand how old they really are, the year, what's going on, how safe it is, and then tell them to connect with me. That's the hardest part, connecting us both, taking that amnesic wall down and us being able to see each other. And sometimes seeing some of those alternative states of my mind showing me memories that I have erased is very difficult. So sometimes the process doesn't get complete 5, 10, 20 times. Once that process is complete and I do see what that alternative state shows me, I am able to have an emotion that's been held back, crying, anger, you name it. It's almost like a shell shock. I can't move. I can't see. I'm frozen. There's been times where I have to wear something to protect myself because I have wet myself. I have dealt with the shaking. I've had nosebleeds from these processes. But the relief I feel after, I wish I could give to you. I can't even describe the relief that I get from this. My CPTSD has been reduced. My pain has been reduced. I still deal with a lot of chronic issues, but I'm able to do more community stuff. My agoraphobia is easing. I hear less noise in my ears. I'm able to focus more on things that I need to. Will everything go away eventually? I don't know. I can't give you that answer because I'm still in the process. But can I share this with you? Yeah. So anyway, let's get back to this.
So they consider this pretty functional in their daily lives. Many of these people view their plurality as a form of diversity and certainly not pathology. So to differentiate between the two, it's important to look for shared memories among the entities, which is what people typically report when they identify with plural identity. It's also good to think about whether the person is experiencing distress due to these disparate personalities, or are they content with their coexisting headmates? Assess the person's function across daily living skills, academics, and social interactions. Listen for the role of social media influence on the person's thoughts about their identity, and explore websites where the patient gets their information and support.
Individuals embracing plural identity may use terms such as coming out and adapt alternative pronouns, introducing complexities for families as they process and accept this facet of their loved one's identity.
I have studied this for over 10 years. I have read over 300 books on the subject of DID, complex post-traumatic stress disorder. I have taken small classes in those that suffer from like suicidal ideation and issues like that. I have trained myself to help those that are struggling with issues like that. I have put in years and years of therapy of EMDR, CBT, DBT, EFT, and now in the process of DNMS. If you don't know what those things are, please feel free to look them up. Now, let's get into Bethany Brand. Now, for this article, this is under bethanybrand.com, and you're welcome to look up the article yourself. Under the research part, it states Dr. Brand has written over 135 published articles and book chapters on topics related to trauma, disassociation, assessment, and malingering, and authored one book called The Conscious Guide to the Assessment and Treatment of Trauma-Related Disassociation, and co-authored 2 books, Finding Solid Ground, Overcoming Obstacles in Trauma Treatment, the Finding Solid Ground Program Workbook, Overcoming Obstacles in Trauma and Recovery. Her research focuses on assessing and treating trauma disorders, differentiating clinical from simulated disassociation, examining textbooks for the accuracy of the material presented about trauma, training therapists to treat traumatized clients, and examining and dispelling myths about disassociation. Dr. Bethany Brand was the principal investigator on a prospective, naturalistic, longitudinal, international treatment outcome study of dissociative disorders. This study, the treatment of patients with dissociative disorders, TOP DID, or DD, was the largest and only international prospective treatment study of dissociative disorders to date. The cross-sectional results showed that patients in the later stages of treatment had fewer symptoms of disassociation, PTSD, and general distress, fewer recent hospitalizations, and better adaptive functioning than those in the early stages of treatment. The longitudinal results indicated that patients showed less disassociation, PTSD, general distress, depression, suicidal attempts, self-harm, dangerous behaviors, drug use, physical pain, and hospitalizations, as well as improved functioning over 30 months of treatment. Over the course of treatment, participants became more involved in the volunteer jobs and/or attending school and socializing, and reported feeling better. Treatment costs also decreased over time as the patients participated in disassociation-focused treatment and the Top DD network programs. Recently, Top DD research team conducted the first web-based educational program for dissociative clients and their therapists. The study based on this program is called the Top DD Network Study. The goals were to teach patients how to improve healthy management of their symptoms of PTSD and disassociation, to stabilize their safety by improving their regulation of emotion, self-understanding, and self-compassion. The results were very promising. Clients showed improvements in disassociation and PTSD symptoms, healthier management of emotions, and increased adaptive capacities. Furthermore, they showed decreased non-suicidal self-injury. This was the first study about dissociative disorders treatment published in the Journal of Traumatic Stress. And that's right here, if you want to check that out. Research investigating how to accurately assess traumatized and dissociative individuals is of great importance because much of the research on psychological assessment has not been conducted using individuals traumatized throughout childhood, sometimes referred to as complex trauma. Okay. As a result, current tests and psychological interviews may misclassify individuals with complex trauma-related difficulties as foreign and exaggerating psychological problems, or as having psychotic or borderline disorders, or other psychological problems. Most psychological tests and interviews were not designed to detect dissociative disorders or complex trauma, nor were they trauma-informed. Unfortunately, many tests include items that may be trauma-related, but that impact of trauma was not taken into account in the interpretive manuals and related publications. Thus, it is critical that assessment research is conducted using complex trauma survivors as participants so that valid and reliable data is developed so that the clinicians can accurately interpret test results for traumatized individuals. Now next I want to get into NAMI, and this is going through www.nami.org, Truth About DID. And these are pieces of that article. DID is complex, but it is treatable, okay? DID usually, if not always, coexists with one or more co-occurrent diagnoses. These might include anxiety, depression, PTSD, borderline personality disorder, and bipolar disorders, to name a few. PTSD is my co-occurring disorder. While my parts are now integrated and they are no longer fragmented into chaotic bundles of raw emotions that engulf me, I still experience flashbacks to my abuse, but I have learned to manage them. Today, I take an off-label, low-dose anti-seizure medication that helps dilute the intensity of flashbacks. Now keep in mind I'm reading something that somebody else had written to explain their story so you have a little understanding on how their journey was. DID, however, can be hidden. In fact, only a trauma-informed professional might observe hints of the disorder at all. Since there are, by definition, two or more separate identities present in the psyche of a person with DID, those of us who live with the condition manage a complex inner world that no one else sees. Long before I came to accept that I had 5 primary alters, or parts as I call them, I hid them from myself. I didn't want to know them. I feared I might have mental illness, and I wanted my parts to go away and let me be normal. This reaction is common. Okay? People with DID are often ashamed and terrified of their symptoms, of finding themselves othered. Now that I am open about my DID, that is what I want people to know. So again, this isn't the full article. You're welcome to go check out the full article if you want. Therapy isn't easy, but it has the power to repair. Finding the right therapeutic fit and developing a trusting relationship with a therapist can take time. It can also take years. My relationship with my therapist was often stormy. I even considered stopping therapy as I struggled to navigate how to be in the relationship, where parts of me openly distrusted him and sometimes hated him. I actually experienced that with my therapist as well. It took me 5 years to even let her near me or talk to me. I just was froze constantly. Over time, I learned to tolerate our conflicts, and all of my parts gradually opened up to him. From there, we were able to identify damage and begin our work to repair. Desired qualities in a therapist and a therapeutic relationship will likely look different for everyone. Even from a position of profound psychological distress, I knew I needed a therapist who practiced mindfulness in its fullness, whose age reflected their experience, whose depth of listening was steadfast, committed, and honest. People often asked why I didn't choose a female therapist considering my past traumas, and I can only answer that the therapist I chose was the right person for me, and gender simply wasn't as significant a consideration. What mattered to me was his mindfulness and his ability to see beyond my diagnosis. As a result, my parts allowed him into our world, and they learned I was truly not alone. So, that's the thing. You may go through 3 or 4 therapists. I certainly did, before you find somebody that meets those needs. Every person that has dissociative identity disorder and their alternative states have needs that need to be met, and your therapy has to be done based on your history, your past, your triggers. That therapist has to get to know you on such a personal level, yet has to put up huge boundaries to protect themselves and you. It's quite a challenge. Telling my story matters. The stigma surrounding DID is formidable and real, and those of us who live with it have an uphill battle in being unheard and understood. It seems to me that many people think first of entertainment, of movies and films about sensational characters with a bunch of different personalities when they hear of DID. They do not know about the human beings in pain and their midst. Ultimately, I believe that the only way those of us with DID can eliminate stigma is if our lived experiences become real to other people. This is a driving force in coming out of hiding to tell my story. And I think they did a really good job doing that. So that's all I have today, and you're more than welcome to take this into your therapy, show your therapist or your psychologist, whichever you prefer. Again, I am not a professional. These are experiences based on my own experience, and also credit to those that write these kind of articles and do audio about these kind of things, because they are giving the truth of what dissociative identity disorder really is. That's all I have. Loves. Bye.